Good afternoon. Just saying hi and hello. Thanks for joining early.
Mhm.
Glad to see that videos and audio are working. We'll
Good
start in a
afternoon,
bit.
Dr. Barcelo. I don't know if you know Darren.
Darren,
Hello.
no, I don't think we've met. Glad to connect.
Hi, how are you doing? Nice to meet you, Dr. Basalo.
We're both going to team up. I'll start up and then Darren does the rest, and then I'll do the final slide, the last slide, and then I'll remain so that I can respond to any questions providers may have. Is that okay?
That's perfect. That's perfect. And Darren, so that I think the motivation to include DMC ODS comes from, oh boy, provider network training maybe 3 quarters ago, when I think we were talking about access to mental health services just kind of more broadly. And as follow-up, some of the providers reached out to clarify, like, how do we get people into substance use treatment? Who do we call? What services are available? So everything that I saw on the slides was just perfect. And yeah, looking forward to the presentation. It's always unclear, how many providers will get in real time in attendance to the session. But please rest assured that slides get circulated additionally, and there's the recording available. So hoping that your message and that good news will be received.
Got it. Thank you. And thank you for the invite.
Absolutely.
Nice to finally meet you, Fatima and Darren. My name is Isa Lyko, but my emails say Maria Lyko. I've been communicating with you
Yeah.
regarding the CalAIM, and there's a little bit of confusion on my part about today's presentation, but yes, thank you so much for being here. It's nice to
Me
meet you.
too. Nice to meet you. I was also confused because of the CalAIM. CalAIM, I would think, is the equivalent of ECM. Am I correct?
Yes, yes.
Okay. But this one
ECM.
is not ECM.
No, this is
There
provider
there
network
you go.
training for all our
Yes,
providers.
yes.
Yeah.
Okay, sounds good.
Okay, thank you.
Would it be possible that the same providers are also CalAIM providers?
Possible, yes.
Because
Because all our providers are invited to these meetings, yes. And this happens on a quarterly basis versus the CalAIM. That's something that we're starting. It's an 8-part training series.
Got it.
Yes.
We also do the same thing with our DMC ODS providers. We meet with them every other month.
Yes.
So,
okay. Yeah. All right. Thank you.
Yeah, nice to meet you.
Nice to meet you. Aaron, I don't know what happened to my background. I'm trying to fix it.
And Darren, just a heads up, Aaron and Isa, don't freak out. The 15 minutes is, I think, flexible. The rest of the training, we don't anticipate to necessarily go the full time. So, use the time you need and we'll go from there.
Okay, thank you.
Afternoon, folks. Thanks to those who have joined. As people trickle in, we'll probably give it just another minute or two before we get started with our formal program. Okay, out of respect for folks' time, why don't we go ahead and get started? Isa or Aaron, I think you maybe were sharing slides.
Yes, just doing a quick tech check to make sure we've got that. I'll go ahead and start sharing now.
Thank you so much.
Can everybody see okay?
I can, thank you. So welcome one and all to CCHP's Provider Network Training for the second quarter of 2025. Welcome to our contracted providers as well as our internal CCHS colleagues. Next slide, please. So we have a robust agenda today. We have a special guest speaker coming from County Behavioral Health Services to speak regarding services available to Medi-Cal members for alcohol and other drugs. We have updates from several departments as depicted here in this table within CCHP that are relevant updates to providers and offering guidance in terms of how to provide best services for CCHP members. With that, why don't we jump straight into content with some programmatic updates. Next slide, please. So this is to just note that there are some new faces here at the Contra Costa Health Plan. There have been some changes in leadership and in terms of supporting your clinics and supporting ongoing services, wanting to make sure who to reach out to under what circumstances, and if you receive correspondence or communications, to know who they're coming from. So Irene Lowe, who many on this call know, has been our Chief Medical Officer. She is now in the position of interim CEO following the departure of Sharon Mackey approximately 1 month ago. Emil Shaw has been with the county as the Chief Digital Officer, and he is now working in greater collaboration with the plan. We're very excited to have the support of our IT partners. Elena White is stepping in as our Interim Director of Operations. Next slide, please. Given Dr. Lowe, Irene Lowe's stepping into the position of interim CEO, Dr. Levin has stepped into the position of our Senior Medical Director, and she is overseeing clinical operations here at the plan. Brandon Engelbert, who some of you may know, who had previously been in claims, is now our Director of Member Services and Outreach. And we welcome Matt Verdier, who is our newly identified and who recently started Director of Compliance and Government Relations. So those are just some new staff. We're happy to have them. And with that, we'll turn it over to Darren Webb, Program Manager for Alcohol and Other Drugs within Contra Costa Health Services, who will present to us a few slides regarding how to refer members to services and what services are available within the delivery system. Darren, hand it over to you, and Fatima, also Chief of Alcohol and Other Drugs within the County Behavioral Health System. Thank you both for being
Absolutely.
Thanks, Dr. Barcelo. I'll go ahead and get us started. Good afternoon, everyone. My name is Fatima Matasol. I'm Alcohol and Other Drugs Program Chief in Contra Costa. We are under behavioral health. We operate the Drug Medical Organized Delivery System. In short, typically it's called the DMC ODS. This is a prepaid inpatient hospital managed care plan, very about the same as CCHP and the same as the mental health plan. Both the mental health plan and the DMC ODS are operated by behavioral health. I'll let Darren introduce himself, and then we'll go into the next slide.
Hello, everyone. My name is Darren Webb, and I am a program manager here with Alcohol and Other Drug Services.
Next slide, please. So today, really quickly, we're going to review really briefly the Memorandum of Understanding between the Managed Care Plan, CCHP, and the DMC ODS, which also governs the Mental Health Plan. It is an integrated Memorandum of Understanding, or MOU. Darren will do an introduction to substance use disorder services in the county. And then we'll talk a little about accessing services, which is what all of you may be interested in learning, so that you can help plan members navigate the system. Next slide. And so again, there is a Memorandum of Understanding that governs the relationship and collaboration and obligations between both plans, between Contra Costa Health Plan and also the Behavioral Health Plan, that again includes both the DMC ODS and the Mental Health Plan. For the DMC ODS, alcohol and other drugs is primarily responsible, or the carve out as CCHP and Kaiser calls it. We are the carve out for services for plan members who have a substance use disorder. This MOU lays the plan and the rules and the agreements in how we need to cooperate with each other, how beneficiaries should receive the care that they should receive. It also is very explicit about ensuring that there are seamless transitions between one plan and the other. And also there's timeliness requirements for how things should be done, including follow-up of individuals who have been referred to us. So today, we won't spend a lot of time on the MOU. I'm sure CCHP has already covered that with all of you. Needless to say, we are here to deliver those services, and the presentation today is actually part of that, ensuring that all of you know how to support your beneficiaries. Next slide.
All right, so Alcohol and Other Drug Services operates the Drug Medical Organized Delivery System. And it's important to know that there is a single entry point, and it's through the Behavioral Health Access Line. The SUD counselor conducts a screening. Based on the results, the counselor will provide a warm transfer to the appropriate level of care. These placements can change once a client receives a full assessment in person. The client must be a Contra Costa County resident with Contra Costa County Medi-Cal. So that's important to know. And the assessment tool that we utilize is the American Society of Addiction Medicine, also known as ASAM. Under the behavioral health SUD services, that would include withdrawal management, also known as detox, outpatient services, residential treatment program, some specialized services, as well as medication-assisted treatment services. We can go to the next slide. So for detox, or as the more newer term, withdrawal management, so those services for withdrawal management, the typical stay in a withdrawal management facility would be 3 to 5 days, but that can be extended depending on medical necessity. Clients are given individual care, management that include referrals to another level of care. All clients are encouraged to attend some programming depending on their symptoms while they're there in withdrawal management. Clients can receive information about medication for alcohol disorders. Also, it's important to know that withdrawal management is a social model. So it's not a medical detox and there is no medical staff on site. The programs for withdrawal management for men would include Pueblos del Sol in the city of Concord. Also, we have Richmond Health and Wellness Center in the city of Richmond. We also, for women, for withdrawal management, we have the Oz Center, which is located in Concord, as well as East County Wallam, which is located in the city of Pittsburgh. And to access the withdrawal management services, we do have, again, the access line number. So an individual would call the access line, or they can call the detox facility directly in order to get placed into a detox bed. This type of services does not require a call to the access line. So it is important to know that if a person is in need of withdrawal management, they can call the detox facility directly in order to get in. Next slide, please. Next slide, please. Additional services also include intensive and basic outpatient programs. So in the intensive and the outpatient programs, the services would include individual and group sessions. Individuals would attend up to 3 hours per day in intensive outpatient. It is evidence-based programming. There are co-ed programs, as well as telehealth is also available at the outpatient level. For the programs, 12 adult there. So as far as programs go, it's important to know there are 12 adult outpatient facilities that offer intensive and regular outpatient services. There is a substance abuse counselors embedded in the mental health outpatient clinics for youth and for adults. Outpatient services are also available for Spanish speakers in the city of Concord and Richmond. And then also again, to access services for outpatient services would also be a call into the access line. Next slide, please. There's also residential services that's available. Residential services, on average, a person, an individual would stay in a residential treatment program for about 45 days. It is based off of medical necessity of the client. All are staffed, all the residential programs are staffed by SUD counselors, which includes a licensed therapist on staff as well. All programs also have a medical director, and it does require authorization for the 3 different levels that are available at the residential program. There are 9 licensed residential program facilities. The programs are gender specific. There are 4 serving women, and there are 5 serving men. The facilities of the residential programs range in size from 8 to 40 beds and are located in all 3 major regions of the county. One of the men's programs is dedicated to Spanish speakers. And then also some of the women facilities offer perinatal services and beds for small children. Next slide, please. And then there's the medication-assisted treatment services. So medication-assisted treatment, also known as MAT for short, can be used as a standalone treatment or in conjunction with outpatient and or residential treatment services. Medications are based on clients' substance use and their current living situation. For opiate users, there's a choice between methadone and buprenorphine. Methadone is distributed at a daily, distributed daily at the office visits until take homes can be suitable for the client. Buprenorphine can be prescribed as any prescription and it can be picked up at any local pharmacy. If Sublocade is recommended, the counselor will work with the PCP. medication for alcohol use disorder through the PCP. There is medication for individuals with alcohol use disorder through the PCP and Let's Recover. The programs for MAT include 3 methadone and the buprenorphine programs located in West and East and Central County. Buprenorphine is available at the Choose and Change Clinic, and it can be prescribed also again by any PCP. Recover also is available to offer MAT services via telehealth. Next slide, please. Additional services for SUD services also includes recovery residents. Recovery residences are a special kind of housing for individuals committed to abstaining from drug and alcohol use. AODS does contract and subcontract with some of the recovery residences in Contra Costa County. These homes are not licensed, but they are monitored by Alcohol and Other Drug Services. Houses are peer-run. Clients are required to enroll in outpatient treatment and actively engage and actively participate in the house. Also, services include recovery support services. Recovery support services would include individual and group counseling. Recovery coaching and monitoring are delivered in person, via telehealth, or by telephone. Linkages for recovery support services also include linkages to child care, there's support services, employment services, job training, education services, and any other services that the client may be identified that they need to be linked to as well. In addition, there also is recovery incentives, also known as contingency management. And that is evidence-based treatment that provides motivational incentives to treat individuals with stimulant use disorder. It's offered through 2 of our outpatient providers. Next slide, please. And then we have our prevention services and programs. So there's primary prevention, which includes education and awareness. There's also information dissemination, youth development, and also youth leadership, the coalition building, and policy and media advocacy which would be social media. And then there's secondary prevention, which includes screening and early intervention and referral. There is EPSD, also known as early and periodic screening, diagnostic, and treatment. And then for the populations that are reached through the prevention services and programs would include parents and families, youth, which include middle and high school age, and also communities throughout Contra Costa County. Next slide, please. And I'll turn it over to Fatima for this last slide.
Yep, this is our last slide, but I think a very important slide. This is, if there's any takeaway, is this one. We have a single point of entry in the county for behavioral health services that includes both for mental health and substance use. It is the 888 number that your beneficiaries should have when they're calling for services. The access line is it integrates substance abuse counselors and also mental health clinicians. And whoever picks up the call, if the need is for substance use, the clinician will do a warm transfer to a substance use counselor, and the substance use counselor is going to engage the caller. Many of the callers are ambivalent, which means they're not quite ready to enter treatment, but sometimes they need to talk to someone. And a substance abuse counselor, by and large, has lived experience. Not everybody does, but most of them do. And they have the skills and the talent to engage somebody on the phone. When the screening is completed, and it's a brief screening over the phone, then a warm handoff is done with the program of their choice. So if they want to go to residential treatment and they meet medical necessity for residential treatment, the counselor on the access line is going to make an attempt to connect with the program right on the spot. And part of the reason is to allow the caller to establish the best time for an intake appointment. And this person will get an appointment on the spot. We are also governed by the same requirements of mental health, the mental health plan, of timeliness and access. And so we have exactly about 3 days, 10 days to give somebody an appointment or some type of service. And so we are meeting those timeliness requirements. But the most important aspect of this is to allow the caller to connect with the other with the counselor on the other side of the call, so that they feel welcome and introduced to the services directly. Also, what's important is, and I want to remind all of you about this, is for medication-assisted treatment and for withdrawal management, there is no need to call the access line. People can directly call the program, or in the case of withdrawal management, in many cases, they just show up at the program, and that's okay. They don't need to call the access line, and the reason is we consider those vital and critical services that need to be provided right away. The residential services would need to be authorized, but that takes place after the client has entered treatment. Because we want to make sure that we create a system in which if somebody is ambivalent, we don't want to add additional barriers to them. And so the access line, remember, only does a brief screening. When the beneficiary shows into the treatment facility that they were referred to, they will be getting a full assessment. And that assessment is follows the American Society of Addiction Medicine, which establishes levels of care. If by any reason there's a change of level of care between the screening done by the access line and the provider, we will work with the beneficiary to make that transfer. But I would say since 2016 that we've been operating the DMC ODS, the discrepancy between the referral from access and the placement has been really minimum, which means we do attempt to synchronize the system through a lot of trainings between providers and the access line staff to ensure that there is good communication and that we remove or eliminate the chances for discrepancies. So with that, I would also say that anybody who calls the access line, if they're not ready for treatment, which happens all the time, then that beneficiary is transferred to a set of counselors that we have here in administration that we call recovery coaches. Those recovery coaches will continue to call this beneficiary for at least 3 weeks just to follow up and make sure that they're following up with their appointments, or that if they were not ready for treatment, that we continue to do motivational interviewing to keep them engaged. And with that, I would say also, last but not least, that in addition to the counselors we have here, we have counselors in the field. We have counselors in the jails. We have counselors at the homeless shelters. We have counselors at the mental health clinics. And we call those touch point locations that specifically target populations that are missing in treatment. And I would just make a last comment. Typically, as a managed care plan, we focus on claims, we focus on the number of people that we serve, but we hardly focus on people we are not serving and who are eligible for treatment. And the idea of having substance use counselors in the field at touch point locations is exactly that, to reach out those that never made it into our system. And with that, I'll stop, and then I'll ask and see if there's any questions from anybody in this call.
Thank you, Fatima and Darren. Appreciate, the emphasis on the access line as the point of entry, and also the importance of the access line, but serving as potentially a part of the process in and of itself for members who are not necessarily prepared to enter into full services, but engaging in that motivational interviewing and moving them along. If there is the need for elaboration or clarification from any of the providers, is there perhaps in the chat you can drop in a preferred contact information that isn't a number, whether it be a group email or someone who can be contacted in terms of follow-up navigation? I want to underscore for folks on the call that everything that was just described pertains to CCHP Medi-Cal members. For CCHP commercial members, substance use services are covered, but they are, managed, and that process would happen through CCHP. I can provide a contact in the chat regarding, if there are questions on how to support commercial members receive substance use services. That would be through Contra Costa Health Plan's Behavioral Health Department. And again, I can provide an email for that department in the chat. If there aren't any questions, I will move to the next slide and our next agenda item. Thank you, Darren and Fatima. You're welcome to stay or drop off. So our next topic of conversation are updates from the Department of Utilization Management here at CCHP. We have, I believe, three or four important updates to share. If we go to the next slide. We want to confirm that providers are aware that CCHP authorizations has transitioned to what's called a service level authorizations process, which means that relative to our prior process of authorizing a referral in aggregate, we will now be moving to a process where for any given authorization request containing multiple codes, we can give a line-by-line response to what is the determination on that code. And so from a provider perspective, that requires a few things. And first and foremost, that requires that valid codes be submitted in a standard CPT or REV or HCPCS format for our review and determination. So for providers who have been previously using custom codes, those are no longer permitted. Portal providers will submit codes in the same way as they had been before. For CCA RMC providers, know that there was an extensive overhaul of your orders such that we would receive codes as expected. And then, with that in mind, what we really want to emphasize is what you can expect as a provider when you get an letter back. So if we go to the next slide, we have two examples of what you can expect to see when you are getting communication from us regarding the outcome of our utilization determination. So we go to the next slide. So here we have two examples, and they're a bit small, but I'm hoping that you can see that these are instances in which an authorization request was not authorized in full. And so rather than sending a denial letter to a provider that leaves you confused, not knowing, what was the problem, what codes were good, what codes were bad, this table will give you a line-by-line account for, any given code. Why was it denied? In the example on the left, these two codes were denied for neither code requested meeting medical necessity. Whereas in the instance on the right, you have a code where the first code was not covered for this member based on, their insurance. However, the second two codes were each authorized. So this, we hope, not only will meet the expectations that our regulators have for how we communicate and review codes, but will provide you better clarity regarding, what happened in terms of the referral that was submitted, how referrals can be adjusted, and as always these letters have contact information if there is the desire to reach out and clarify the determination of a given code. Next slide, please. Speaking about regulators and our oversight, we do want to be transparent in sharing with you recently identified opportunities for improvement from both the Department of Healthcare Services and the Department of Managed Care, our two primary regulators here in the state. And so beginning with the Department of Managed Care, our last audit was in the fall of 2022. And as follow-up for the Department of Utilization Management, there were three opportunities for improvement or corrective action instances in which we were out of compliance. The first of which was that the department determined that our denial letters did not consistently include a clear and concise explanation as to why something was not authorized. And so we have been working since 2022, but of late, all the more so, to provide to you and to members a more explicit, accessible reason as to why an authorization request may not have been approved. The second finding from DMHC was that the contact information for a peer-to-peer, which I just described, was not consistently included. The third relates to post-stabilization care, which is a means of coordinating inpatient hospitalization for members who are being stabilized in the ED. And we will provide follow-up regarding that finding to our contracted hospitals and have accessible information on our website for the out-of-area hospitals that may be seeing our members. From DHCS in 2024, we had a finding very similar to that given to us, the first listed there from DMHC, which was that denial letters did not adequately explain why a member was not authorized for a given service. And so again, I think that we're working for both findings on clearer communication to members and providers. We do have upcoming audits this fall from both of these regulators. We hope to have corrected these findings, and we will, of course, circle back to you all, letting you know the outcome. Next slide. So in terms of new benefits for members and processes that you may need to be aware of, the following two slides come from legislative updates. And so, on an ongoing basis, elected officials are submitting bills to our state government. In the case that those are approved and are relevant to healthcare, on an annual basis, we receive guidance from the Department of Managed Care related to all of the bills that had been approved over the last year. We are then given a timeline by which to implement each of these essentially new laws, right? So this table includes a brief overview of the relevant Senate and Assembly bills. It provides their number and a 1 or 2 line description of what was passed. I do want to say that this is for the purpose of your awareness only. We will provide follow-up with more detail regarding the implications of these changes and how they might impact your practice. But I'll call out a few. Those include Senate Bill 1120, which prohibits our utilization of artificial intelligence to conduct the clinical review in utilization management. So that each auth request that is submitted to the plan is reviewed by a human clinician who is reviewing documentation and making clinically appropriate decisions regarding medical necessity. Another relevant or highlight, SB 729, which expands access to diagnosis and treatment of infertility and fertility services. My recollection is that this will be for commercial members only at this time, and again, further information to follow. To go to the next slide. I will call out, just one more as an example, coverage for PANDA and PANS, AB 2105. This relates to ensuring that all appropriate diagnostic treatment be provided for young people so as to prevent these autoimmune conditions, and is already in effect. I will note that many of the services that would fall under this bill are services that do not require authorization, but our team is on the lookout for any service that does come in to ensure that we make the appropriate decision. Are there any questions regarding updates? If not, I'd be happy to pass it over to Beth, who can present on quality updates.
Thank you. If anyone has a question, just please jump in. I will go. You can go to the next slide. So I have a couple different topics to cover today. First, I just want to, for primary care groups on the call, I want to make sure that you're aware of all of these different reports that are now available to you on the provider portal. Previously, we'd been sending these via fax or encrypted email, and now we have a very nice process for all these reports to be collated on the provider portal that you can run regularly. We have a variety of different reports. These include panel reports, gap in care reports, some other things on quality measures. We worked over the fall time to give access at a PCP group level, as there's a lot of PHI. Each organization designated specific individuals to be given access. If you do not have access and feel like you should, if you can work with whoever your administrative admin is at your provider group to request, and they have a link to the request form. And if you have any questions, you can email me at that cchp.quality email. You can go to the next slide. So one topic I wanted to cover today was the initial health appointment. This is specifically for new patients who are assigned to your practice. So these are people who are new to Medi-Cal, and it's looking about getting people into established care with you as their PCP. So this is supposed to happen within the first 4 months of them enrolling in the health plan, and is really looking at a physical, looking at collecting social history and health history, and working on preventive health services. And individuals that are due for an initial health appointment can be found on that provider portal of whether they've completed one or not. So we do try to keep that updated, and that report updates daily. If you go to the next slide. Also, I wanted to talk a little bit about lead screening for children. This has been an area of improvement for us in quality with our CCHP network. So the first thing that I wanted to just mention is anticipatory guidance. And so anticipatory guidance is supposed to be given at every well care visit between 6 months to 6 years of age about the risks and effects of childhood lead exposure, and about the requirement for testing if the child is behind on their testing schedule. And that anticipatory guidance should be documented in their medical record. And blood lead testing is supposed to be occurring at age 1 and 2. And if the child hadn't received a lead test and is under 6, they're supposed to have a catch-up test. And there's a little bit of information on there of billing CPT codes. Next slide. We have a number of resources on our website for lead screening. We have some posters, we have patient-facing health ed handouts, other outreach materials. Those are all available online on that link that we'll have posted. And then we also have that children due for lead screening that's available on your provider reports, which I mentioned at the beginning. You can go to the next slide. And go forward one. And I just wanted to know, after a lead screening occur, all the results do get reported to the public health department. And if the child's lead screening is high, the health department will be following up with them. You can also report that directly if it is an elevated level. And their level of care really depends on what that screening is, whether it's education. They may have home visiting out there with case management and have a full environmental investigation. Next slide. I also wanted to briefly mention about appointment access. In California, there are some very strict appointment standards in terms of urgent care and non-urgent care for appointments. Standards are there written 48 hours for urgent care if it does not require prior auth, and 96 if it does. And then non-urgent care appointments supposed to be available between 10 or 15 days, depending on the appointment type. Our regulators, the Department of Managed Healthcare in the state of California and the Department of Healthcare Services Agency, do some monitoring calls on these. So your provider's offices may be getting phone calls on a very regular basis in terms of saying that there's a surveyor asking about their appointment availability. These are required to participate in. We've had a number of refusals for this, and I just wanted to note that the state is requiring participation in these surveys. And they will be starting to hand out sanctions this year for non-participation at the health plan level. So we're really trying to educate people on these surveys that are going out, let you know what the standards are. If you have any questions, please email me on the email address that we've been given. Next slide, please. Other update I wanted to give is on a new high-risk HPV testing protocol that is recently rolled out for cervical cancer screening, the self-swab cervical cancer screening. Last year in May, FDA approved self-swab high-risk HPV testing in a clinical setting. And so there's two different machines that have been, or two different tests that have been approved. This isn't home testing like fit kits. This is not yet approved. That's still in clinical trials, but these in-office self-swabs are a very exciting development that we're wanting to let everyone know about that option. So both LabCorp and Quest just recently launched their self-collection kits last month. So these kits can be ordered directly from Quest and LabCorp for in-office collection, and then the sample is suspended in a solution and sent back to lab. If you haven't received any information from Quest or LabCorp on this, please let me know and I can send you what I have received from them, and then you can reach out to your Quest or LabCorp rep. And again, patients that are due for cervical cancer screening can be found on the Gap in Care list on the provider portal. Next slide. And I just wanted to remind everyone on interpreter services that are available, whether that's telephonic, in-person, directions are on here. I know we talked about this in depth at the last provider training. You can go to the next slide. And this is also translated services. So if you need any documents translated for patients, those can be sent to that email address. Please remove PHI if possible for a quicker turnaround unless it's required for the document. Next slide, please. And then I also wanted to let everyone know about some upcoming trainings that the Department of Healthcare Services and CMS are going to be having for us this year. So the first is one that we've already completed. That was due in June. This was an early periodic screening, diagnosis, and treatment training for providers who see people under 21 years of age, and that's going to be required biannually now. The second one is a diversity, equity, inclusion training. We do have those slides and videos posted on our website, and you can see the links below to do those, and we will need an attestation. That's going to be needed to be completed by all providers by the end of the year. And we are also, then it's going to be done upon re-credentialing for providers. And then the last one is a training that we have yet to be released. We are going to become a DSNP, a Medicare Medicaid health plan next year. And there's going to be a short training on our model of care. And so this one, we're going to be rolling it out in tandem with the DEI training, which is available. But I just wanted to say that's coming up. I know these are a little off camber trainings that when you're normally doing these on re-credentialing. So I just wanted to note those as you'll be seeing emails eventually. Next slide. I think that's all I had. Okay, if you had any questions, please let me know and I'll hand it over back to Dr. Barcelo to talk about our DSNP.
Thank you, Beth. Okay, so for the DSNP, these slides are intended to, provide some heads up regarding the direction in which the plan is moving when it comes to launching a new line of business, which will integrate the Medicare and Medi-Cal benefits for those members who are eligible for both forms of coverage. And so this is a unique type of Medicare, essentially Part C plan, for which these dual eligible members only are eligible. As the single Medi-Cal plan within this county, again, other than Kaiser, we do have the requirement to launch the DSNP and anticipate that those Medicare members who would elect to receive all of their benefits coordinated under a single entity have the option of opting into our DSNP. And so really this intention here is to provide a single source of healthcare administration for these members. They have but one member call center. They have but one department of authorizations, one department in which to file grievances, and can receive better integration and care coordination along the way. So this is something that we have been working on now for several months and will continue to spend the rest of 2025 preparing for. We plan to launch in January 2026. Some of you may already be seeing members who are Medi dual eligible. And, as we move forward, we will, be keeping providers in the loop regarding who is now entering into this new line of business, all of which would be housed under CCHP. Next slide, please. So this is just a timeline to show you where we are. As Beth just hinted to, we do anticipate later this year releasing a provider training on our model of care, which I will describe in the next slide. We will again be reaching out to members, given the fact that this is a voluntary enrollment in Q4, and ultimately launching in January 2026. Next slide, please. Just a brief description, as some of you may already anticipate, members who are dual eligible are more likely to have a higher disease prevalence, suffer multiple comorbid conditions, have polypharmacy, have DME needs, have certain social risk factors which serve as a barrier to optimal health, and for whom there are subpopulations in which case tailored care management services can be provided to improve their coordination across multi-specialty providers and in some cases, institutions that are relevant to their functional or cognitive limitations. Next slide, please. So in light of the unique needs of this membership, we do anticipate a unique opportunity for providers to participate in their care. The model of care is a document that is greater than 100 pages that was drafted here within the plan that we submitted both to the state and to CMS, which we are very excited to have received a glowing score of 100% in terms of meeting requirements of what would be expected from a plan and outlining how they propose to care for these vulnerable members. And that training, as Beth mentioned, will become available for providers in Q3. And what we anticipate here is, that providers be given and be given the opportunity to weigh in on how we as the plan can support members in identifying their needs, identifying those providers who are relevant to those needs, and then ensuring that those needs are met. And so in addition to the model of care, we do have HRAs, we do have interdisciplinary care teams, which are the forum in which those conversations can be had, and then individualized care plans, which are the document that is reassessed on an annual basis at the minimum to reflect the conversation in the interdisciplinary care team and as identified in the health risk assessment. So we'll be partnering with existing providers as well as new providers to address social drivers and clinical drivers of health. We do anticipate new opportunities to partner in data sharing for quality purposes, echoing some of the information that Beth shared in her presentation. Next slide. In terms of the data sharing and the importance of quality, many quality metrics that we currently adhere to will be relevant to the DSNP. That said, we do anticipate the inclusion of additional quality metrics and means of measuring those outcomes. And so this, will require not only the timely visit, but appropriate coding. We are hoping to provide guidance regarding clear coding regarding the complexity of member diagnosis through ICD-10 and HCC coding. More to come as the year progresses, but ultimately something that will be essential for the success of the DSNP line of business. Next slide, please. This is echoing, I think, what's already been shared. There will be onboarding and training for providers coming in Q2, Q3 of this year. We are open to hearing feedback and look forward to collaborating with you on this launch. Next slide. Okay, with that, I'll hand it over to Brandon, who will speak briefly on transportation for Medi-Cal members.
Cool. All right. Hello, good afternoon. Next slide, please. I skipped over the introduction part. My name is Brandon. I'm Director of Member Services, among other things. But starting off with just kind of an overall principle of how we look at transportation for Contra Costa Health Plan. NMT service requested must be the least costly method that meets the member's needs. This statement clearly specific to non-medical transportation, but that's how we kind of look at transportation writ large. We're looking within the scope of cost containment of providing the least costly way to get a member from point A to point B, whatever their Medi-Cal covered service would be. Next slide, please. The transportation benefit, what is it? So transportation services available to Medi-Cal members with no other means of reaching a covered service. You have essentially two types of transportation. You have NMT, non-medical transportation, pardon me, and non-emergency medical transportation, or NEMT. To get these rides going, you would call the number you see down below, 855-222-1218, or member services, 877-661-6230, option 2, to be connected with live folks to get you through that process. Next slide, please. Specific to NMT, so NMT includes rides by sedan, paratransit, back one slide, please, thank you, taxi, Uber, Lyft, and public transit. So NMT is for members who can essentially ambulate. They're able to walk around and get out the door and into the car. NMT is used for appointments covered under Medi-Cal. That includes ancillary and durable medical. I should have just stuck to the acronym, huh? DME, durable medical equipment. Next slide, please. So for requesting NMT, you would call our transportation line. That's Monday through Friday, 8 to 5. We ask for a lead time of 5 to 7 business days to get this going, but we're also not blind to the reality that sometimes you get an appointment lined up. And so the rule of thumb there would be the sooner the member knows about it, the sooner they could get us engaged in trying to set their ride up. Yeah, we can step back to that. It might be in a later slide too, Sarah, but I'll make a note to come back to that momentarily. At the point of getting this kind of set up, our expectation would be that the member, whoever is coordinating the transportation for them, would have appointment details ready at time of call, including the appointment date, appointment time, provider name, and provider phone number. The attendant or caregiver may accompany the ride. Unaccompanied minors can get there without anyone, provided they have consent forms signed by their parent or guardian, provided they are seeking sensitive services, or they are emancipated. For instances where you have a car seat or somebody who requires a car seat, it is the member's responsibility to get that hooked up and installed properly in the car. That would never be on the driver to do. That's no different whether you're doing private transportation on your own dime or through what CCHP coordinates. Thank you, Isa. So there's the phone number in the comments for that earlier question. Next slide, please. NMT booking and notification. So we use Roundtrip. That is our booking partner. Roundtrip has a 24/7 navigation center available at 877-396-8080. Roundtrip in general makes calls and text messages from the phone number 215-309-9702. Worth noting, particularly for those of you who are selective in the calls you allow through, you would want to make sure that that phone number is whitelisted so it doesn't run into any kind of spam filter that somebody might have active and running on their respective mobile phones. From Roundtrip, you would receive information including the ride being booked, a reminder about the ride that has been dispatched, the assignment, arrival, related delays, or cancellation. And then there are rides that are a will call, where you will be dropped off, and then it would be on the member to let the service know when you are ready to pick up. That would be texting back that phone number go to let them know that you are awaiting pickup to be brought back to your original starting point. Next slide, please. And let me pause because I know I at times talk too quickly. If you have any questions, please drop it into the chat. I am watching it, or just say it out loud. But yeah, next slide, please. So for troubleshooting and reimbursement, where I'd love to believe we can always get everybody lined up with their rides, that doesn't always work out that way. There are times on occasion issues, including we can't find a ride, too short of a turnaround, there's a delay, there's just something that gets in the way of complicating it. So in those instances, the member or their caretaker would want to get a hold of that NMT vendor to see what's going on. And if you're not getting a timely resolution to that, would be when you get back on the phone and get a hold of somebody on my team, the CCHP transportation people. In instances where CCHP cannot arrange a ride in time, members are certainly able to book it themselves. Please, 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 pretty please hang on to your receipt, because you would be turning that back into us for reimbursement on a case-by-case basis. So if this turns into a bigger deal, we certainly could escalate that onto our ECM management, and members, as always, are always welcome to turn this into a grievance if it's something that they feel is deserving of that kind of treatment. Next slide, please. Now on to NEMT, non-emergency medical transfer. This is for members who need some kind of elevated assistance of getting from point A to point B. These are people who are maybe not necessarily able to ambulate, so to speak, due to their medical conditions. NEMT modes include wheelchair vans, gurney vans, non-emergency ambulance, and I had to twist my own arm to put in the air transport stuff. I'm not aware of any time where we're going to book an air ambulance, but certainly these situations could happen where this would be something where you get authorization to go by air to get from point A to point B. This, of course, requires, in all these instances, prior authorization and a physician certification statement. Without those, there can be no NEMT booked. Next slide, please. Exceptions and transfers. So prior authorization, a broad stroke, is not required, generally speaking, when it's a facility transfer. So in this instance, we're talking ER to inpatient, or hospital to a SNF, to an ICF, or psychiatric facilities. A transfer, however, must happen within 3 hours of request. And again, same as earlier articulated, if CCHP cannot get this in time, hospitals are able to book this themselves, and CCHP would, of course, cover the applicable expenses of that transportation. Next slide, please. The last slide. So if you run into situations where the answers aren't really articulated in what I just went through, or just something unique, you are more than welcome to get a hold of the transportation line. That's 1-855-222-1218. If the individual operators aren't helping you out, you can elevate it up a notch to either one of Cynthia Laird or Belkys Toodle. Cynthia being kind of the one in charge of transportation, and Belkys is kind of our jack of all trades, manager and member services and things like that. But those are their emails. You can write them down. I understand the information will be made publicly available as well, something to click through later. But that is it from me on transportation. Any questions before I pass the torch? Cool. I got nothing more. Thank you all for your time. Next slide, please.
Thank you, Brandon, for that presentation. With that, we'll hand it over to Lazel for a presentation on case management.
Hi, good morning, everyone. My name is Lazel Avicilia. I am the Director of Case Management here at Contra Costa Health Plan. Next slide, please. Next slide, please. All right, so today I will be discussing the CCHP case management programs that is offered under CCHP Case Management Department. Next slide, please. All right, so our goal in CCHP Case Management is to support our members in navigating the healthcare system and improving their overall well-being. There are 3 case management programs under our department. There is our complex case management, which is geared more towards our higher risk members. This is higher risk members, meaning any member who is a transplant candidate, or members who are prescribed 15 or more medications, or they have 2 or more hospitalizations and ED visits, we do enroll them and classify them as under complex case management. Under that, we also do have our care coordination program, which is geared more towards anyone who is not eligible for complex case management, but still need some help in navigating the healthcare system. Additionally, we also do have our transitional care services program. This is for our high-risk members who are transitioning from one care setting to another. So this is our members who are in an inpatient setting and needs help and is not involved in any of the other case management programs and needs help for their post-discharge follow-ups. We do enroll them here. They are enrolled in transitional care services for at least 30 days post their discharge, or if they have been connected to a more ongoing case management support. Next slide, please. Oh, I kind of already covered. So again, complex case management, this provides intensive care coordination for our members with more complex medical and psychosocial needs. Just to note that this type of case management program is an opt-out program, and members do have the right to decline services if they don't want to participate. Under this program, they do receive a comprehensive assessment of their healthcare needs, including questions regards to their long-term services and support needs. And we also do provide care planning for these patients. And we do refer them to the appropriate community resource programs out there. And we do provide transitional care services under this program if they're already enrolled in case management, in complex case management. Next slide, please. Again, under care coordination, this program is geared more towards needs-based, and we do connect the member to whatever identified need they have during the referral or when we interact with them. Similar to our complex case management, this is an opt-out program. If the member does not want services and do not wish to engage with us, we will not enroll them in care coordination. All right, we kind of already covered there. All right, transitional care services. Like I said earlier, this is to support our members who are transitioning between care settings to make sure that they have the appropriate post-discharge support to eventually help reduce their avoidable readmissions. Members in this type of program do have the right, they do not have to engage with us. We can do the transitional care services coordination in the back end even if the member does not wish to engage. Again, this is extended and available for high-risk members for at least 30 days post-discharge, and this applies to discharges from hospital, SNFs, and other healthcare settings. Interventions include reviewing discharge plans with the members, ensuring medication reconciliation, coordinating post-discharge services and follow-ups, addressing any barriers to safe discharge with the care teams, and screening and referring the members to a more ongoing case management program, like complex case management and enhanced care management. Next slide, please. Okay, all right. So how do you request for case management services or how to contact us here in CCHP Case Management? Providers can, for our Contra Costa Health providers, you can enter the referral via Epic by just entering the referral type CCHP Case Management, and there's some questions out there that you will need to, what type of services this patient needs and all of that. On the other hand, for our contracted providers, you can enter it through the CC-Link provider portal. And then the specs I have put on here, referral type is case management, location and place of service is contracted place of service, vendor will be contracted vendor, and then the service codes are also there. It's T1016, PR case management. Or you can also call us in CCHP Case Management at 925-313-6887, and a receptionist will then enter the referral on your behalf. And then you can also fax a referral form at 925-252-2609. And for more information, you can give us a call. That will be all for me. Thank you very much. Is there any questions? All right. Thank you very much.
So unfortunately, Peja had to step away from the call, and I will present briefly on CalAIM programs, specifically ECM and community supports. If we can go to the next slide. So this is a segue from Lazel's presentation regarding the range of case management and care management services that are available to Medi-Cal members. Again, these services are not available, at least with regard to ECM and community supports, to CCHP commercial members. ECM is the highest level of care management available to Medi-Cal members and is again, a statewide benefit addressing both clinical and non-clinical needs for the highest needs members within our population. It provides intensive coordination of services, including in-person expectations and very regular outreach to the member. As emphasized in the last bullet, please keep in mind that ECM and community supports exist independent from one another. And so many members who are referred to ECM may also then be referred, doesn't have to be sequential, but may also be referred to community supports to support their needs as identified in their ECM plan of care. Members may also receive community supports separate from ECM. So the eligibility criteria are different. We have, different providers offering services depending upon whether we're talking about, which community support, but they can be received a la carte and or synergistically to meet the member's needs. If we go to the next slide, we can look at specifically the fact that ECM is both for members with the highest needs and for those members who meet explicit and defined criteria coming from DHCS. We refer to populations of focus, which are listed here, that are separate for children and adults, each of which has criteria. And so, it is not simply the need, for example, that someone have the need to connect with a mental health provider. They must be eligible for services specifically in the specialty mental health system of care, and have other risk factors that then qualify them for ECM. So please refer when in doubt and understand that if ECM authorization requests are denied, it may be because the member did not meet that eligibility for highest need members based on either their pattern of utilization or other risk factors. Next slide, please. So in terms of community supports, again, separate from ECM, but synergistic and coming to us from DHCS, these are services beyond the scope of traditional healthcare services that are intended to intervene on social needs that are relevant to disease outcomes. And so similarly, they have defined eligibility criteria, and they are not forever benefits necessarily, right? Many of them are time limited and or, to bridge a need to move a member and their health in the direction of greater independence, greater sustainability, and more optimal management. So if we go to the next slide, we see a list of the community supports available. These can be found if you're working with CC-Link in RMC by opening orders and typing CalAIM. They can be requested via the portal using guidance that is available when you sign into the portal and or that can be made available as follow-up from the CalAIM team. So this is a list. It is not intended to provide all of the details regarding the eligibility criteria or duration of authorization, but gives a reminder regarding what CCHP is covering. And if there is, a request for additional information, please feel free to reach out. Next slide, please. So accessing ECM and community supports, these are available at least for authorization request by calling member services. Again, that would prompt a referral that would need to be reviewed to ensure that the member meets eligibility criteria for one of the identified populations of focus. If they do, and we would then pair the member with a provider based on that population if the member themselves did not, were not familiar with which vendors provide which services. Otherwise, as mentioned, RMC providers can access both ECM and community support referrals by looking for CalAIM. Instructions are provided regarding portal entry, and there are instructions regarding outreach to the CalAIM department for questions and escalation as they come up. Next slide, please. Okay, with that, I'll hand it over to the compliance team for their presentation regarding updates and all plan letters.
Thank you, Dr. Barcelo. I'm Otilia Teuton. I'm one of the managers in the compliance department, so I will go over a few of the all plan letters that we are working on recently. Next slide, please. So some of these things that we receive are, these all plan letters are from DMHC, which is Department of Managed Healthcare, and some are from DHCS, Department of Healthcare Services. So the difference is that the DMHC health plan letters, they can pertain to all members, all our product lines, or sometimes the letter will say this is only for commercial members, or this is only for medical. So, but they could apply for all HMO product lines. So just wanted to make that clarification. So, and some of these are very, very high level where they just state, here's a reminder for this, for example, this first one, APL 25008, is a reminder that we have a provider directory and annual filing requirement that we have to do. So pretty much what the compliance department does, we look at these all plan letters, we determine what departments need to be involved, we send them instructions, and then we have to submit the different reports or different filing requirements that the state has. And these APLs, they come with a lot of details of all the steps we have to do. So just wanted to explain that. The second one, it is a more in-depth one where there is a new requirement that claims are being processed and reimbursed within no later than 30 calendar days. So this is something that will start January 1st, 2026. The next one, APL 25006, talks about the health plan covering mental health and substance use disorder treatments provided to an enrollee by these 988 centers or mobile crisis team. So this is just kind of stating that make sure health plans that you pay these services, and gives us details of how to do that. And then the next one, 25005, this is an additional guidance on the Southern California fires. We have very few providers in that area, but it was pretty much an extension that providers have up to 365 days to for submitting their claims or resubmitting or dealing with disputes and things like that. So pretty much just extending the timeline. 25004, this is an APL that goes into detail only for commercial evidence of coverage. So evidence of coverage is a booklet that we send out to all our members, and we have it on our website. And pretty much the MHC just said, here are all these new terminology, such as explanation of benefits, member rights, definitions, things like that, that we want you to have in your booklets. Next slide, please. The next one, 25003, this is these two large group renewal notice and off exchange filing requirements. These are very high level, just pretty much talking about our contracts and how we need to renew certain filings that we have to do. The next ones on the bottom here are from DHCS. So 25005, and some of them have the same number which with the MHC, but they're different APLs, which makes it a little bit confusing. I just wanted to explain that. This first one has to do with determining threshold languages for our members. So what happens is the state will give us every 3 years, they will give us a report that says, we have looked in your community and we believe that the Medi-Cal eligible population in Contra Costa speak these languages, and you need to have all your materials, member materials in these specific languages available. So for us, it is Spanish and Chinese as additional from English. And what changed this year is that we have more traditional Chinese members, so we translate most of our materials in traditional Chinese. So that was the default. And what's new is that now they want us to have the default as simplified Chinese, unless the member has specified that they want traditional. So it just, what we have to do now is have all our materials available in simplified and traditional Chinese in case the member requests one or the other. And then community reinvestment requirements. This is an APL that talks about the health plan having to reinvest a part of our net profits back into the community. And 21008, this one is pretty much an update to a previous APL. And the state just sent us a list of additional tribal federally qualified health centers that our members can go to. And then the last one, this is, let's see, establishing dual eligible special needs plans. This is information around, let's see, DSNP. So the new contracts that we talked about earlier, that now our members or we will accept in 2026 members that have Medicare and Medi-Cal. So it's pretty much some contractual requirements in some of the filings that we have to do. So that is all for the APLs. Any questions? If not, I will pass it on.
Okay, thank you, Otilia, for that presentation. And in terms of the last section, it looks like this was added on, and I think Beth has already presented some of the highlights regarding accessing interpreter services, linguistic services. And so just a reminder, you know, this is an expectation of providers when working with members for whom, you know, that language capacity is not available in clinic. We do have telephonic interpreter services that can be accessed using the number provided and the guidance so as to ensure that, you know, CCHP is identified as a relevant provider. Please have the listed information available at the time of making the call. And, you know, in-person services are available, but do require planning. This telephonic option is a service that is available as needed. Next slide, please. Here we have guidance regarding the in-person and face-to-face interpreter services that are available. We do request advance notice, and there is the option of submitting an online form. Also, please note the contact information if there are questions regarding the availability or troubleshooting interpreter services for telehealth appointments. Next slide, please. Again, echoing what Beth already shared in her slide, if there is a request from any of your clinics to translate documents for members, you can email those documents to the email provided. Again, removing PHI as possible and encrypting that correspondence, we can get it back to you from there. All right, I think that is our last slide. So this concludes our Q2 provider network training. Our Q3 will be scheduled, I anticipate, in the first month of the upcoming quarter. Please feel free to reach out if there are questions, concerns, and hope everyone has a great afternoon.